Good morning, everyone. I have the privilege of introducing our first speaker of the day, Dr. Shukla. Dr. Shukla is an associate professor in the Division of Infectious Disease. He completed medical school at the Medical University of South Carolina and public health education at the UNC Gilling School of Public Health. Afterwards, he completed internal medicine residency here at Jackson Memorial Hospital, University of Miami, and fellowship training at UT Houston and MD Anderson Cancer Center. His primary research interests include multi-drug resistant organisms, including VRE, CRE, and Candida auris. Dr. Shukla serves as medical director for infection control for UHealth, where he helped direct the COVID-19 pandemic response for the health system. During this time, he also became engaged in research related to SARS-CoV-2, including its impact on healthcare-associated infections, linking of local predictive models to hospital operations, and wastewater surveillance. He is also actively engaged in medical education by way of longitudinal pathways related to healthcare management for medical students and IM residents, and directs an internship program in infection control for public health students. Please join me in welcoming Dr. Shukla.
Hi, good afternoon. Thanks so much, Dr. Weiss and Rebecca Lewis, for inviting me to speak. So I was asked to speak today about updates in healthcare epidemiology. I don't have any relevant disclosures. Just to give a little bit of an outline, I'm going to speak first just a little about what healthcare epidemiology is. I think many people are not familiar. Oftentimes people ask me, well, what do you do anyway? So I'm going to try to explain that to a certain degree to give you some background. And then I'll go into some trends of different infectious syndromes and organisms that we're closely watching, talk a little bit about how we respond to these, both internally and externally, and then close out with some future directions and scholarly work. So who are we? So this is my team. This is for the UHealth team. Clarification that my colleagues at the VA and Jackson have separate teams. So this is for our UHealth group. We cover all the 3 acute care hospitals in the system, as well as the 145 plus clinics in 4 different counties. So we rounded all these places. So if you see someone walking into your clinic, looking around up and down at the ground, the floor, it's probably one of my staff looking at opportunities for infection prevention. And what do we do? I'm going to go into a little bit in the next slide. So our primary role here is in terms of our day-to-day is prevention of and spread of infections. And this is not something new. I think infection prevention has been around as long as civilization. Separating clean and dirty, separating sick from healthy is essentially, at the core of what we do. The infection preventionists who I just showed you pictures of come from different academic backgrounds. Some of them are from microbiology, some from public health, some from clinical backgrounds like nursing, and they have their own professional certification process. And then this is just showing you a little bit of how we connect to different parts of the functioning health system. And you can see it's basically all over, from IT to emergency management to HR. We sort of interact with all elements of the health system. A little bit more detail of what we do in here. To reiterate my point about how this is not a new thing, you can see here a paper from the Lancet published in 1955 outlining what infection prevention should be. And you'll see some of the same things here in the list that I outlined. So we do primarily epidemiology and reporting for the health system. We do surveillance at the local, like at the individual clinic and hospital level, and do outbreak management. We do a lot of staff education and research on best practices and disseminate that information to staff. We produce a lot of policies that people often misquote, but we produce a lot of policies related to infection prevention. We're very involved in disinfection and sterilization. So those of you who do procedural specialties and use scopes or other medical devices, we oversee the process of cleaning of those, as well as the maintenance. As you know, even if you have one transmission event from one procedure, it can completely wreak havoc on the service line. So it's very important to prevent infections from medical devices. We also devise infection prevention programs, which is just a fancy way of saying QI projects for my health management colleagues out there. We're involved in design and construction. So as you know, we have lots of facilities popping up all the time. So we go and look at the design and make sure if there's going to be a procedural, there's going to be a clean and a dirty room. If there's a disinfection requirement, how that's going to go, whether it be proper air management, water management, et cetera. So we look through the processes there. And then we also look at control of MDROs, which is a new emerging threat, which I'll talk about and a little more detail in the subsequent slides. And then also provide, serve as sort of a link to occupational health when there are outbreak events. So it's a lot. So what do I do anyway is all that stuff. So why does it matter? Well, first and foremost, for the patient. So quality and patient safety is the number one reason to do this. No one should come into a healthcare facility and leave with an infection they didn't already have. So that's the primary goal. And it's a very important thing. If any of you have ever had a patient who's had a healthcare associated infection or a family member, et cetera, it can be very distressing for good reason. It's also important for reporting and reimbursement. It's a big deal in terms of quality for CMS, which reimburses health systems with large amounts of money. And also for regulatory agencies like the state agency in Florida, for example, for healthcare administration, the Joint Commission, which most people are familiar with. And so all of these, and just to give you an illustration here, I have a picture here of one of the 200 pages of the Joint Commission requirements outlining some infection control requirements. So again, you're going to see the exact same thing you saw on the last slide from 1955. A lot of the same practices are there in the Joint Commission standard as well. And then the second point is a lot of reporting to state and local health departments, as well as to the CDC. So now just shifting a little bit, and I'll talk a little about what are we watching now, what's going on now. So I'll go into it by, in a very nice ID differential way by organism type. And a lot of these you're going to see in this framework of the One Health model, because infectious disease, I think, very closely falls in line with this framework of the things that we eat, the way we do animal husbandry, the way we raise plants and how we consume them, how we travel, et cetera. All of this works into how infectious diseases can spread and can be prevented. So you'll see that sort of paradigm play through in all these trends. So what viruses are we looking at? So you guys may remember the Mpox epidemic from not too long ago. This is a nice paper illustrating the whole sequence of events that occurred. By January 23, the emergency was declared over. And as many of my colleagues in ID can tell you, we're continuing to see cases. So I think this virus needs to be closely monitored because it retains, I think, epidemic potential. We've seen breakthrough cases from vaccines. We've seen difficult to treat cases in highly immunosuppressed patients. So we're continuing to see these in our ID clinics, and we need to keep a close eye on that. What about the very popular respiratory viruses? So I'll talk about coronaviruses and influenza. So this is just the weekly report from the health department for Miami-Dade showing you the trends of influenza-like illness. And this is really a surveillance definition of people who present to the emergency room with fever and respiratory symptoms. And as you can see in the bright pink, hot pink line, that's this year's ILI season. And it is closely tracking with the blue line, which was the past year. So as you can see, the erratic things that were there in other colors from the past year during the pandemic have sort of eased into a more regular pattern. And basically, this is suggesting COVID is entering into a regular respiratory virus season pattern like flu. And here's a trend of hospitalizations from COVID, just to give some closure to what happened with that. You can see, obviously, we had numerous peaks and surges, and then it has all tapered down into very few hospitalizations, primarily occurring during the respiratory virus season. So what's on the horizon? So this is a map from the USDA showing cases of H5N1 influenza, so bird flu, which you may have heard about in the news. It's a specific clade, which is, I think, 2.3.4, something like that. A lot of numbers. But essentially, this clade has been identified in a number of different mammal species. So those of you who are Disney enthusiasts, this virus would not be good for Zootopia. They've basically been detected in everything from seals, dolphins, to deer. And this is just a map from the US, but certainly been detected in other parts of the world as well. And there recently was also a human case, and there was another one a couple of years ago. So this particular variant maintains a very high epidemic potential, and we really need to keep an eye on it. And again, you can see the sort of One Health paradigm playing out again here, because what's going on in animals may well spill into humans at any given time. So we have to keep an eye on that. And then lastly, I'll talk a little bit about measles. So here's a trend of measles cases over the past decade or so. And you can see that when the pandemic began, this sort of uptick in measles cases that we've been seeing sort of silenced out for a while. But now, again, we're starting to see cases. Many of you guys might remember early in the year, there was a famous outbreak in Broward County related to school and unvaccinated children. And this basically led to a systematic response from us to be prepared for any potential cases entering our system. And Again, it's not that we had any cases, but this is one of those highly infectious diseases that we need to keep an eye on because there could be an outbreak at any time. So moving on from viruses to bacteria. So there's not a whole lot of new bacteria in the horizon. They sort of get renamed every now and then. But there is a lot of concern regarding antimicrobial resistance in bacteria. This is something I'm sure you'll have seen at any of our hospitals. It leads to a lot of interventions in terms of isolation, cohorting, specialized staff, specialized cleaning, et cetera. Because a lot of these bacteria, for many of these bacteria, there's no known antibiotics that we can treat. The antibiotic pipeline has run quite dry. There's not an incentive for pharmaceutical companies to produce new antibiotics. And so there's a bit of a limitation there in terms of what we can offer in some of these cases. And some of these you've probably seen in your microbiology lab results if you've had any patients at any of our hospitals, like resistant Acinetobacter, C. diff, carbapenem resistant, Enterobacteriaceae, and the list is so on and so forth. So these are the CDC's characterization of these antibiotic resistant organisms. So urgent is the worst, basically, that we should be really trying to mitigate. Serious is sort of the next worst, and then concerning are things that we sort of should watch. So those are kind of, from a bacteria perspective, what we're keeping in the back of our mind. And these saw huge surges during the pandemic period. So this is an international phenomenon that was seen. There were outbreaks of resistant Acinetobacter, of CRE, et cetera. So resistant Pseudomonas. If you search the literature, you'll see all kinds of publications about different outbreaks in COVID units and so forth. So this remains a big threat in modern clinical care. And then switching a little bit to bacteria causing sexually transmitted infections. And of these, the three main ones are very prevalent in South Florida, so they all should be looked out for. You can see here the increases over the past decade in terms of number of cases. And in Florida, this is just showing you syphilis, and also we're on the list for congenital syphilis as well, but we're number 17, and for the other two, we're in the top 25. So certainly see our share of cases here in South Florida. And then there's also concern for drug resistance in Neisseria, gonorrhea specifically, and that's also in the threat report from the CDC. Moving on to fungi. So fungi are sort of the new players on the block in terms of concern for epidemic pandemic potential. This is a very nice illustration from a paper speaking about Candida auris. Many of you guys have probably heard about it by now. We certainly have a lot of it in South Florida. And this organism is interesting and unique because it sort of emerged in 5 different parts of the world at the same time, about a decade or two ago. And there were different clades. In other words, they were not genetically related. So this diagram kind of shows you where they may have emerged from aquatic environments, potentially through animal reservoirs into the healthcare setting. And they're difficult to treat because they're resistant to first-line antifungals. They're very adherent to surfaces. They transmit readily through fomites. And so this obviously becomes a big issue for obviously acute care, but also facilities that don't have the infection control infrastructures, such as post-acute care facilities like your LTACs and so forth. So the organism has done a very good job of spreading and coming from the environment. So it's a bit of a sort of poster child for things we may potentially see coming from the environment in the future. And it is also listed as an urgent threat on the CDC threat report. And then we've also started seeing drug resistant with fungi. So those of you who, especially my colleagues who work in immunosuppressed population, you've probably seen resistant Candida species. You've also probably starting to see resistant Aspergillus infections. So this is another sort of following in line with the bacteria running out of antifungals and development of resistance, sort of the ongoing battle there. And then on the side, the endemic fungi, which we don't see a whole lot here in South Florida, but certainly in the US we do, Histococcidioides and Blasto. If you think back to your, step 1 days, you probably had a question about someone who went to the San Joaquin Valley and say, oh, that's coccidioides, And now if you look at the range of coccidioides, it's spread all the way from Utah to the Midwest. So these endemic fungi, presumably because of travel between different areas by humans, but also because of the global warming and climate change, are spreading sort of beyond their historic geographic ranges. So these are all worth keeping an eye on. And then moving on to vector-borne diseases. So you guys are probably very familiar with mosquitoes, but also ticks have spread quite a bit geographically. There's a number of different genre and species of ticks in the United States and the northern latitudes that have spread sort of their geographic range over the past 2 decades. On this the review paper kind of nicely illustrates that. You see the sort of the red line where historically you see a lot of these insect vectors, and then the dark blue purple areas are where they've kind of expected to spread over the next 2-3 decades. And then that's sort of the geographic range. And then on the second panel, you can see the altitude range is shifting as well. So where you didn't usually see these vectors at higher altitudes, we're expecting to see them at higher and higher altitudes as those areas become warmer. And so what are some of the diseases they carry? Well, all of the different categories I already went through. They carry viruses, they carry bacterial infections, they carry parasitic infections. So I'm kind of giving you a laundry list there. The one to kind of watch out for in South Florida, I think, is really dengue. This is some data from the health department. Again, you can see here in green, those are the cases of dengue that were presumed to be from travel, so which is what we historically saw. And the blue bar kind of shows you where the patient said they hadn't traveled at all. And you can see clearly there's sort of an uptick over the last couple of years in cases that are locally acquired. So very important to, reinforce your prevention practices to yourself and to your patients. So, keeping standing water sites out of your backyard, using good mosquito repellent when you're outside, and so forth, because some of these organisms are already transmitting locally. So moving on to healthcare associated infections. So what are they? I kind of want to give a little bit of a background because I think there's a lot of confusion sometimes when we're doing some investigations of these cases. So we generally think of these infections clinically because they have clinical definitions. Certainly the IDSA has definitions and other professional societies do. Yeah, the list sort of there of some of them. But the CDC actually uses surveillance definitions. So surveillance definition is kind of like what you would expect in a disease spreading in the community. So they're very strict, like the patient has to have a catheter for this many days, they have to have had the blood culture occur this many days, et cetera. It has to be this type of organism, et cetera. So the clinical definitions don't always match up with surveillance definitions. But in order to standardize the data collection nationwide, it makes a lot more sense to have a standard surveillance definition. And then in order to adjust for different hospital types, case mix index, and so forth, they use a standardized infection ratio, which is some of you who work in quality may be familiar with a standardized mortality ratio. This is kind of a similar concept, trying to standardize the number of cases across different health systems. And then these data also get fed into the HAC program for CMS, which feeds into quality and reimbursement as well. So, and some of the common ones you're familiar with, CLABSIs, CAUTIs, I'm sure you've heard of those, surgical site infections, which we don't always deal with in medicine, but is a big area of ongoing work and opportunity on the surgical side, C. diff, VAEs, and then MRSA, which you're also, I'm sure, familiar with. So that's what healthcare associated infections are. So how are they trending? And this is data that actually I'm proud to say we were probably one of the first to publish on in EID in the first year of the pandemic. Many hospitals had stopped reporting them in general because they were too overwhelmed. And we identified a sharp increase in particularly VAEs and CLABSIs during this time period. And then shortly after publication, many more people started publishing, and now we have sort of the retrospective look back at how many cases were going on. You can see this sort of baseline trajectory, and then once the pandemic started, a huge shift up. The good news is the last report from the CDC, we're starting to see decreases in CLABSIs, CAUTIs, no change in surgical site infections, a little bit of an increase in arthroplasty, surgical site infections, but overall we're seeing some downtrend. So hopefully in this year's report, we'll continue to see improvements. So moving forward, this is Miriam Levy. She's our executive director for UHealth for infection control. This is her getting a turnaround chain at one of the directors' meetings back in January or February of 2020, looking very uncomfortable, smiling, knowing that we had our work cut out for us coming up. Ended up actually having her cell phone was actually the first COVID hotline. She got 100 or 150 calls a week from everyone from medical staff to parents of students at Gables. And so there was a tremendous amount of work involved in planning, but even with the best planning, the work can be daunting. So just to give you some examples of how you would respond. So first I'll give you sort of an internal outbreak situation. I have a picture here. This is a true picture, true story. Can anyone tell me what might be wrong with this picture? This is the toilet. Suppose you wanted to go use it. What would you do afterwards? Wash your hands, but where would you wash your hands? There's no sink, right? So this was a few years ago. This is actually the one bathroom for patients in the PACU area in the main hospital. And we were investigating a C. diff outbreak that we basically linked to potentially this area, the patients walking out, not having any place to wash their hands, and it's sort of spreading in the environment. So of course, there was a lot of response to this. Now there is a sink there and signs to wash your hands and so forth. Obviously, you want to do a multifaceted response. But just to give you some framework of how you identify an internal outbreak. So you want to identify stakeholders. So in this scenario, we have the facilities people involved. We have to have leadership involved. We have nursing involved, and so forth. You want to develop a list of commonalities, which we would commonly call a line list in a public health setting. You want to narrow the sources and then potentially do some environmental testing, which we actually did in this situation, and then develop a mitigation plan. And so this is something, a project like this could go on for several months, but it's important to prevent any further cases. And some of the things that we've investigated in the past few years, I've kind of outlined there, just for your interest, and we've certainly seen many more. And then what about external threats? Are you guys familiar with this picture? Anybody know what this is? Anyone know the name Jon Snow? Not the Night's Watch and, Winterfell or any of that. So this is the original Jon Snow from Broad Street in London. And he's, back in the 1800s, was investigating a cholera outbreak that he linked to this water pump that everybody was using. And then the story goes that he removed the little handle on the pump, and then the outbreak ended. So this is much more complex when you're investigating a potential external outbreak that's involved in your health system. So you need to have ongoing surveillance to look for these things. So some of the things that we do as sort of a proxy to the health department is do our own surveillance of people getting admitted with specific things, right? So if you realize, for example, we have a lot of flu cases coming in from this LTAC, then you can report to the health department not only that these cases are coming from there, but there may be an outbreak going on at that LTAC, right? So recognizing that external hazard and then reporting it requires a lot of surveillance. And then you want to identify the scope and impact. So the picture I just showed you of Miriam standing there, I think she realized very much what the impact and scope of a COVID planning meeting was going to be and what it was going to look like. It was going to be a big thing. And so you need to recognize that so you can plan adequately. You want to assemble stakeholders in this situation, not just within your facility, but also external stakeholders, so people from other hospitals, the health department, and so forth. And then you want to make an operations plan. So we actually have an emerging special pathogens plan that we review every couple of years with emergency management. It's like 250 pages long. And the idea behind it is that you plan out every little thing that could happen if this hazard entered. So as you can imagine, during the planning for COVID-19, we pulled out the emergency pathogen plan and went through how we were going to use that plan. So luckily, we had just reviewed it in 2019, October, so we rolled it out just in time. And then you want to educate your staff about how to identify cases and so forth coming from external sources. And here I put some examples. A sort of more recent example that we've investigated would be the MDR Pseudomonas. You may have seen some of my emails or the news about an outbreak linked to eye drops. So we actually were the first to identify this. We had patients coming into 5 different Bascom-Palmer clinics with the same keratitis, did culture, recognized it's the exact same organism, did a line list, recognized those eye drops, reported, et cetera, and then ended up becoming actually a national problem related to those eye drops. So a lot of these things come in, from our ambulatory clinics. It's very important to do surveillance there. For example, our first COVID case was actually in PAC in the OB clinic. Our first Mpox case was actually in the Walgreens clinic. So you never know where patients are going to show up to seek care. So it's important to be available at all places. And then sometimes we don't get any cases, but we plan anyway. And measles is a good example of that. We, a couple months ago, rolled out a full education plan, testing supplies, et cetera, for any of the clinics in the system that see pediatrics. So it's a lot more extensive doing planning for external hazards. So moving on, so opportunities and things we're working on for strengthening the program. I think the 2 key areas would be expanding capacity for research. And I'm going to give you a little example here. So during the pandemic, when the early days of the pandemic, we realized that the models that were already out there for predicting surges didn't really fit well with what we were seeing. So I worked with one of our data analysts and we created the first prediction model that was based on a number of flights coming from New York and things like that, events going on in the city and so forth. And then we got involved in this grant for doing wastewater surveillance, which was kind of a new novel thing at the time. And that project actually led to boosting that model to be much more reliable. And it ended up being the model for linking everything to operations for like 2 years. So we knew how many staff we needed during a surge. We knew how many supplies, how many people would potentially be out and so forth. The model was very greatly enhanced by this new tool, which Otherwise, we probably wouldn't have known about it in medicine because it was getting explored in the engineering world. So, developing collaborations is very important, and sometimes environmental scientists or people who you don't normally interact with for research can provide a lot of insight. So expanding on this, and then expanding also on our understanding of antimicrobial resistance. So we put in a grant for HRQ to look at C. auris, for example, and hoping to have a scientific meeting here in January to bring some collaborators into the city to talk more. And then also conversely with public health sciences, we didn't really have an expertise in our department of infectious diseases. So we're trying to expand that and recruit people to make that more robust as well. And then training for the future, there's some literature out there that there's an aging population of infection preventionists. We're expecting somewhere, but depending on which study you look at, 20 to 40% vacancy rates in the next 20 years. So it's a big concern and a big push from professional societies to recruit more people. In light of that, we've created an internship program, which we've had for about 2 years now, where we take the public health students and have them rotate with us in the hospital and learn infection prevention. I'm trying to make that into a more formalized certification course with public health sciences, and also potentially develop a graduate program. We applied for a CDC grant for workforce development, which hopefully should help with that if we get it. And then finally, engagement and training of ID fellows. Most of our ID fellows are very clinical, but what they don't realize is if they go on to practice in a community hospital, they may get asked to do healthcare epi. And so I think it's an important skill set that we need to develop more for ID fellows as well. So in summary, infection prevention teams are necessary for patient care, but also required by a lot of different agencies that I showed you. There are a lot of new and evolving pathogens out there, but doing surveillance and response is not new. It's something we've been doing as human beings since the beginning of civilization. Mitigation of transmission really requires a lot of cooperation between multiple stakeholders. We're likely to see multiply drug-resistant pathogens emerging from the environment. And the training and recruitment for the workforce is essential to being prepared. So that concludes my talk. Thank you so much. Open to questions.
Thank you, Dr. Shukla. Very nice review. Thank you very much. We have 1 minute for a question. One disease that you didn't mention that I'm reading a lot about in terms of subclinical presentation is polio. And it seems to be, given the, which was once an eradicated disease, never seen, is now not yet in the United States, I don't think, but certainly worldwide, and given travel and all the things that you've told us before. How concerned are you, and are you monitoring for polio in wastewater?
So we're currently not, but there is a push to do that. There was a grant put in with the NSF to expand the surveillance that we're doing in wastewater. But yes, there were some reports about having detection in wastewater, not here, but in other parts of the US. So it is definitely something we're watching closely.
Thank you. Thank you very much for the excellent review.
I'd like to introduce our next speaker, Dr. Mahfouz. Dr. Mahfouz is a staff physician of advanced endoscopic gastroenterology here at the University of Miami Jackson Memorial Hospital. He completed medical school at the University of Aleppo Faculty of Medicine in Aleppo, Syria, and internal medicine residency at Mount Sinai Medical Center in Miami Beach. He went on to pursue gastroenterology and hepatology fellowship here at the University of Miami in Jackson, and advanced endoscopy fellowship at Mayo Clinic in Jacksonville, Florida. He has numerous publications and presentations, including on the hepatic complications of inflammatory bowel disease and on the evolving role of advanced endoscopic techniques in hepatology. He is joining us today to speak on the topic of the approach to biliary access in patients with altered anatomy. Please join me in welcoming Dr. Mahfouz.
Okay, good afternoon, everyone. Thank you so much for inviting me to speak today. I'll be presenting a very interesting GI clinical vignette. Then I'll be talking about approach to biliary access in patients with altered anatomy. So starting my presentation, I have a 72-year-old male with a history of perforated gastric ulcer who underwent partial gastrectomy with a Billroth 2 anatomy reconstruction in Venezuela and cholecystectomy, and that was many years ago. He presented with epigastric abdominal pain for 2 weeks, new onset jaundice, weight loss, pale stool, and dark urine. His lab work on admission was remarkable for elevated liver function test with a total bilirubin of 13, AST 377, ALT 475, alkaline phosphatase 776. CT scan of the abdomen and pelvis on admission confirmed our concern, which is head of pancreas mass that measured 4 by 4 by 3 centimeter with a central necrotic focus, abutting or invading the duodenum with vascular involvement and lymphadenopathy. There was an evidence of previous cholecystectomy and severe intra and extrahepatic biliary dilation. The common bile duct was severely dilated to 2 centimeter with abrupt narrowing at the level of the ampulla. So there was a concern for metastatic disease with both hepatic nodal lymph nodes, and the next step for this patient actually now is to obtain tissue to confirm the diagnosis and to achieve biliary decompression, as this patient likely will need chemotherapy in the very, very near future. But this case has some challenges. As I mentioned, this patient had a Bellroth 2 anatomy. What does that mean? That means he had a distal gastrectomy with anastomosis between the body of the stomach and the jejunum, which makes because of this anatomic variation and the change in the GI anatomy, that would alter the landmark, and that will make the way to the ampulla to perform biliary intervention very, very long. It's going to be more difficult. So technical difficulties will be associated with this, as we see on the right picture, on the right. Yeah, Bellroth 2. And the risk of complication is higher with this procedure because we're going to go through unfamiliar pathways. On the other hand, if he had a Bellroth 1, which you do end-to-end anastomosis, you will have just the same anatomy as you expect to do ERCP. So we started with an upper endoscopic exam, and we confirmed the Bellroth 2 anatomy. However, he also had something we call Brown anastomosis. If you look at the picture on the top, when they form an omega loop with the jejunal anastomosis, the papilla couldn't be found, or actually more accurately, couldn't be reached because it's too far. An endoscopic ultrasound exam was done. It was technically difficult because the area that we needed to target was the head of the pancreas, which usually we evaluate from the duodenum. And as I mentioned, the duodenum is too far in this case, so we had to evaluate the head of the pancreas from the stomach, which means we had to look through the neck of the pancreas and through it to obtain the biopsies from the head of the pancreas. So the head of pancreas mass was identified, only portion of it actually was seen, and we obtained the biopsies. We also saw small lymph nodes, and we confirmed the dilation of the common bile duct. Now we have tissue. The next step was actually to decompress the bile duct, which is very important. So ERCP was done here, but we had to use a pediatric colonoscope fitted with a cap. Reason we decided to do it with a pediatric colonoscope, as I mentioned, the way to the ampulla is very, very long. So the colonoscope is longer than the ERCP scope, so we had to use it. We were able to identify the gastrojejunal anastomosis, the jejunal anastomosis, and even we reached the ampulla. We were able to see it, but cannulation failed due to unstable scope position, difficulty aligning the sphincterotome with the trajectory of the bile duct. So we placed a tattoo and the afferent limb. This is basically just to facilitate potential future endoscopies that this patient will need. Now we have a failed ERCP. We have to decompress the bile duct. What should we do? Do nothing and hope for a miracle, pray for the patient. Miracles can happen every day. Or consult IR for percutaneous drainage, or do EUS-guided hepatogastrostomy. The decision was made to proceed with EUS-guided hepatogastrostomy. I'm not going to be very technical. I'll try to be as simple here. So basically, we passed the EUS scope. We were able to identify a target in the peripheral biliary duct, and we were able to trace that duct into the left hepatic duct and into the common bile duct. We puncture that duct with the 19-gauge needle. Bile was aspirated to confirm the axis. Then a wire was passed all the way into the duodenum. After that, the tract was dilated to 4 millimeter. Then a metal stent was placed, communicating the stomach into a duct in the liver, like a peripheral duct of the liver. Then through that stent, another plastic stent was placed, communicating the stomach to the peripheral bile duct, to the left hepatic duct, common bile duct, all the way into the duodenum. So as we see here in the pictures, if you look at picture number 10, this is the dilated bile duct. Picture number 11, this is when the duct was punctured. Then the wire was passed in picture number 12. Picture number 13, this is when we dilated the tract. Picture 14, this is the metal stent placed. And then finally the plastic stent placed all the way, communicating stomach, liver, then all the way to the duodenum. Clinical course. Next day, patient was tolerating diet. Procedure went fine. Liver function test trending down. Patient was discharged home. Pathology a few days later confirmed the diagnosis of invasive ductal adenocarcinoma of the pancreas. Labs after 1 month, almost normalization of LFTs with a T bilirubin of 1.5, AST 25, ALT 17, and alkaline phosphatase of 97. IR performed a biopsy of one of the suspicious liver lesions, came back negative for carcinoma. Patient established care with oncology and started on chemotherapy for neoadjuvant and potentially curative intent. And he's scheduled to repeat his ERCP for stent exchange in 4 months. So goal achieved. We got our tissue, confirmed the diagnosis, and the biliary decompressed. Now, I'll be speaking a little bit about altered anatomy. What do we mean by altered anatomy? This is basically when you have a surgery in the upper GI tract that alter the anatomy. We see this a lot in gastric bypass, in Roux-en-Y gastric bypass, Whipple procedure, or liver transplant when they perform hepatocogenostomy. If you look at the images here, this is not like a conventional road that we take usually to do an ERCP. So we have to come up with different techniques. Since it's a very, very long way to make it to the ampulla to perform biliary work, the first thought was actually, why not using a longer scope as we did with our case? So this is when CAP-assisted forward viewing colonoscopy or enteroscopy came. And now we use it also with device-assisted with a single or double balloon or spiral enteroscopy. However, there are limitations to that. So the lack of side viewing and using the elevator, which is crucial in our ERCP, and the length of the endoscope that prevent us from using our accessories, our equipments to intervene on the papilla. For example, in Roux-en-Y gastric bypass, if you look at the picture on the right, if you want to use an enteroscopy-assisted ERCP, you have to go through the gastric pouch all the way through the rulum, then make it up to the jejunal anastomosis, go into the biliopancreatic limb, find the ampulla, then do your ERCP. This is very, very, very hard. It's doable, we can do it, but it's very hard. Since everyone likes shortcut, we had to look for a shortcut. If we couldn't find it, we can create it. And this is how edge procedure actually was invented. By creating a fistula between the excluded stomach and the gastric pouch. If you look at the picture on the left, by creating that fistula using a lumen-opposing metal stent, we can actually perform ERCP with our beloved duodenal scope and just do it in the conventional way. So this is how edge procedure was invented, which is EUS-directed transgastric ERCP. Now, which way is better? Is edge better or enteroscopy-assisted ERCP? They did an international retrospective multi-center comparative trial when they looked at 60 patients. 30 of them went EUS-guided ERCP, edge procedure versus 30 who underwent entero-assisted ERCP with double balloon or single balloon. There was higher technical success rate with the EUS group, 100% versus 60%. The total procedure time were significantly shorter in the EUS group. There were similar adverse events in both groups. And more importantly, there was no significant weight change after creating that fistula in follow-ups after 209 days. Now, I'll be talking very briefly about other US-guided interventions that US-guided biliary access interventions that we performed. When do we need those? We need them usually when standard ERCP cannulation fails. It's very rare, as we're very good in ERCP, but that still can happen. Or when ERCP is not technically possible, the ampulla is not accessible. Common scenarios in that, when you have head of pancreas mass obstructing the duodenum, and you cannot access the duodenum, or if you have a gastric outlet obstruction, so access the ampulla is impossible, so we have to come up with something. That's when EUS transmural approach actually was invented, which is basically the formation of connection between a segment of the biliary system and the GI lumen. If you ask anyone a few years ago, this was just hypothetical. No one has ever done it. And then it became an interesting idea. Say, oh, okay, why not? Why we don't try it? Then few people start to do it. And nowadays, it's widely performed. We can perform EUS-guided choledochoduodenostomy, EUS-guided hepaticogastrostomy, as we saw in our patient, EUS-guided gallbladder drainage, and edge procedure. Going back to our patient, EUS hepaticogastrostomy, we can use this method actually as an initial choice. If we know the anatomy and everything, we can just start with it, or as a salvage therapy when the standard and the device-assisted procedures are not feasible, as we did in our patient. In a multi-center prospective study that included 10 centers in Japan, demonstrated that EUS biliary drainage for malignant biliary obstruction in patients with surgically altered anatomy appears to be both effective and safe. They looked at 40 patients who had various altered anatomy procedures, and the EUS-guided biliary drainage was performed as primary biliary approach in 31 patients and 9 as a rescue therapy. The technical success rate was 100%, and the clinical success rate was 95%, with the mean procedure time 36.5 minutes only. This procedure is good, it's cool, but of course we have adverse events. The rate of adverse events remains high in the literature, and mainly stent migrations or bile peritonitis. In a retrospective study enrolled 120 patients who received EUS HGS for malignant biliary obstruction. They reported 7 episodes of stent malfunction, 10 cases of bile peritonitis, 4 bleedings. Regarding the late adverse events, they reported 2 cases of bile peritonitis, 2 cases of localized infected biloma, 39 cases of late stent dysfunction, and the most common cause was actually stent obstruction from food or sludge. EUS-guided biliary intervention versus enteroscopy-assisted ERCP. And this is the approaches usually we do for altered anatomy cases. An international multicenter comparative cohort study at 10 tertiary centers, colonoscopy-assisted ERCP versus EUS-guided intervention was studied. The clinical success was achieved in 88% patients in the EUS group compared to only 59% in the enteroscopy-assisted ERCP. And also, the EUS group was significantly associated with shorter procedure times. And also, regarding the adverse events, even though it was 20% reported, the authors actually commented the majority of the adverse events were mild or moderate. Now, EUS versus percutaneous drainage after failed ERCP for malignant distal biliary obstruction, which one is better? IR to do the PTC or EUS guided? So they did a systematic review and meta-analysis of studies, with a total of 10 studies were included, including 4 retrospective studies and 6 randomized controlled trials. They saw no difference in technical and clinical success rates between the 2 routes, the PTC and the EUS group. However, procedural adverse events and total adverse events were significantly lower in the EUS group. The delayed adverse events were no difference. This meta-analysis actually indicated that endoscopic biliary drainage is equally effective, but maybe a little bit safer than PTC. Now, EUS-guided gallbladder drainage. We can achieve this as gastroenterologists in 2 ways. Either, if you look at the picture on the right, we can place a stent, transpapillary stent, from the ampulla all the way into the gallbladder to decompress it. We can achieve this via ERCP. Or we can do it transmurally, when you create a route between the gallbladder to decompress it into the stomach or into the duodenum. We can make that decision either before the procedure or during the procedure, and that usually depends on the anatomy or the cystic duct patency or coagulation status. In a three-way comparison, if we look at the picture, they compared percutaneous gallbladder drainage, cholecystostomy, versus endoscopic gallbladder drainage versus EUS-guided gallbladder drainage. So they performed a systematic review and comparative meta-analysis in high-risk acute cholecystitis patients who deemed not to be fit for surgery, which is a very common scenario we see in the hospital. So what it showed that the clinical success in the EUS gallbladder drainage group was significantly superior to the other approaches. Yes, in the PTC group, they have a good technical success. The clinical success was lower than the EUS group. All complications were comparable between the groups. As expected, the most common complication in the PTC group was stent migration or occlusion. In the EUS group was perforation and bleeding, and in the endoscopic group was pancreatitis. Now, the key takeaways, I think that we need to have a tailored approach to these complex, challenging cases. We have the expertise that we need in Jackson Memorial and in University of Miami to perform these challenging cases, and advances in technology and techniques to improve outcomes. EUS and ERCP, they're very important tools, and they can complement each other in approaching these patients. And that would be my presentation.
Thank you, Dr. Mahmoud. For someone like myself who gets lost using GPS downtown Miami, I can imagine what it must be like navigating the pathways without GPS in someone's surgically altered abdomen. Nevertheless, I'm intrigued by how you might consent a patient whose intellect is like mine, that not very great, as to what the options are, and how do you explain this to them sitting in the bed wondering what procedure you're going to do on me?
Yeah, of course. So you have to be really good in drawing. So we try to draw show the patient some graphs. We kind of expect what the challenges that we're going to face before the procedure. So we try to be as thorough as we can and all the scenarios that we could run into. So for example, our patient with the Bhavarth 2, we know it's going to be challenging EUS and challenging ERCP. We explain to the patient before even we start, hey, plan A is going to be using the colonoscope to go all the way down. Then if that fails, we're going to do another procedure, which is the EUS guided. And this is the reasoning why we do it. And of course, we have to explain what risk is associated with each one. And we have to explain to the patient what's the alternative. We have to tell him, hey, there is always a choice of draining the bile duct through the skin, the percutaneous drainage. Not so many patients would be happy with it because no one wants to leave home with a bag, actually, and that will cause them a really downsizing in their quality of life.
So that's really the selling point. You tell them that if you get the external drainage, you're going to end up with a stent and a drainage bag for some time.
It's not a selling point. You have to do the best for the patient. You have to present all the options,
Right.
and they decide at the end with everything that you present them okay, this is what we do, this is what others do, and this is what we think you should do, and all these things.
Mm-hmm. Okay, yeah, Dr. Martin.
Consultation care, patient has cholecystitis, maybe biliary tract disease, critical recommendation for cholecystostomy. I want to comment on that because general recommendation patient also after decompress biliary breathing, the definitive. How can the GI service patients get to that?
Yeah, absolutely. So this is a common scenario. We see it a lot in the hospital. They evaluate the patient with acute cholecystitis, and then the patient is deemed not to be clinically fit for surgery, which is the best next step for acute cholecystitis. These patients will never be, usually they will never be clinically fit if they're not clinically fit now. And the reality, they would leave with no clear plan to remove that gallbladder. And they would leave with a tube hanging there, and maybe they will live the rest of their life with it. So I think here there is a role for us to intervene and perform these procedures.
Okay. Well, thank both our speakers today. This was great. Appreciate both of your participation in Grand Rounds, and everybody in the audience. Please pay attention to the chat in order to get the link for the CME and MOC. Thank you, everyone.